I have some disclosures. I have done some different kinds of educational activities with several of the large pharma companies. And here is a picture. I think most of you have seen this before. It's the ozone hole that people became aware of during the 1980s. And eventually it got clear that it was related to the use of fluorocarbons. And one source of CFCs was as propellants in asthma COPD inhalers. And I remember hearing about this at a meeting in Madeira. I think it was in 1990, and there was a very skeptical, I must admit, British person who said, "Who cares that a few penguins get sunburned?" But fortunately, things have moved on since then. So what did happen? Well, we got something called the Montreal Protocol that was ratified in 1989, and which the decision of it was to stop using devices that contain CFCs. And as you can see, things like this take time. So the last CFC containing asthma inhaler was produced 2013. But instead of CFC containing asthma inhalers, there were 3 different options. One, which we'll talk quite a lot about here, is the PMDIs, which contain HFCs as propellants. But then we also have the soft mist inhalers, and we have the DPIs. And is there a problem with the HFC containing inhalers? Well, they're much better than the CFC containing inhalers. And you can see when looking at ozone depletion, which was the problem with CFC that we were aware of at that time, the HFCs don't have that effect. But they do have a drawback, even though it's less than for the CFCs, and that's the global warming potential of HFCs. And you can see that compared to CO2, which is what we usually compare it to, the most commonly used HFC is 1,430 times more potent when it comes to global warming potential than CO2. And there is also another one that is which is 3 times more potent. Now, different countries had different preferences when it came to what kind of inhaler to use. And this is data from 2011. And what you can see here is that there was a very large difference between the UK and Sweden. So in the UK, the PMDIs, they were about 70% of inhalers used in the UK were PMDIs, whereas in Sweden it was less than 10%. Now, what was the reason for that? Was the reason that we knew, even though we didn't know, that HFCs were bad for you? And of course, that wasn't the reason. Now, I think the true reason for this difference was actually that we had a very powerful pharma company in Sweden, which was called Astra at that time. And it's now a Swedish-British company, AstraZeneca. And they had this device called a turbohaler, and they were really efficient in promoting that in Sweden and not so efficient in other countries. So I think that was the reason why Sweden became, DPIs became very dominant in Sweden. But let's look at the PMDIs again. Is there a problem with the PMDIs? Well, there is. And the reason is the thing I talked about before, that they are very potent greenhouse gases. And we tried to look at differences between asthma or COPD treatment that is based on a DPI compared to one that is based on purely PMDIs. And here we're looking at different GSK products. So if you have a PMDI-based treatment for one patient, it will be CO2 carbon footprints of almost a half a ton. Whereas if you use a treatment based on DPIs, it will be about 19 kilos. So it's a 20 times difference. And how important is that? Well, if you look at an individual patients, it is almost the same as having the difference between having a plant-based diet or a meat-based diet, or if you change from a gasoline to a hybrid car. So it's quite a big difference. And we will talk a little bit more what it means in a more larger perspective. But before we do that, it's important also to say that DPIs isn't the only solution for this. Also, the soft mist inhalers there is the same difference between soft mist inhalers and PMDIs, just because the soft mist inhalers also don't include propellant. Now, how large is this difference? Well, this is from a review paper from Ashley Wilcock and others, showing that in England, the use of PMDIs account for 30% of the National Health Service carbon emissions related to delivery of care and 3% of the total NHS carbon emissions. And what we did show in the paper, I showed you some results, was that if in England, because we had data from England at that time, had the same kind of pattern of use when it came to inhalers, about 2.5% of the total carbon emissions of the NHS would be reduced. Now, the thing is how to do this. Well, one thing that you could do is to try to replace PMDIs with DPIs in ICS and ICS LABA maintenance treatment. And we had a study that I was part of where we tried to look at whether that is possible. And we used data from a pragmatic trial, the Salford asthma study, and we compared the different treatment arms. We compared the treatment arm where the maintenance treatment was given by a DPI, and the other one where it was given with a PMDI. There was no real difference when it came to rescue treatment. And we showed that with the DPI arm, there was better asthma control, but also a large benefit when it came to carbon footprints. So that's one possibility, and it's very doable. The other possibility, which is very doable in many countries, perhaps a bit more difficult in your country, is to replace PMDIs with DPIs when it comes to reliever therapy with short-acting beta-2 agonists. And when we compared data from England and from Sweden, it was data from 2017. We showed that in Sweden, only 10% of the SABA used was PMDIs, whereas in England it was 94%. So it's very different how we look at reliever therapy for asthma in the UK and Sweden. In the UK, almost everyone is absolutely certain that you need a PMDI for this purpose. And in Sweden, everyone is certain that you don't need it. Instead, you can use a DPI. And here you see some examples of different DPIs. So that's another possibility how to reduce carbon footprints for asthma COPD treatment. A third option is to reduce the need for SABA by improving asthma control. And we and others have found that asthma patients that use a lot of SABA, they have less control of their asthma. They even have a higher risk of dying because of asthma. So reducing the need for SABA is a very good thing when it comes to asthma control perspectives, but it's also a very good thing if you look at carbon footprints. Because in fact, if you look at it from a European perspective, you can see that 2/3 of the carbon footprints of inhaler therapy is related to the use of SABA. And we just made an example that the annual carbon footprints of inhaler therapy from these countries was the same as 1.5 million gasoline cars going for 1 year. But the important thing is that 2/3 of this was actually from the use of SABA. So if you reduce the use of SABA, you will reduce the carbon footprints of inhaler therapy. And then another thing is to reduce the need for SABA in asthma management by using ICS formoterol, giving by a DPI in reliever therapy. And as you all know, the preferred reliever therapy in asthma since 2019, at least according to GINA, is as needed low-dose ICS formoterol. And there is abstract at the ERS 2022 looking at this, comparing data from the UK, comparing giving ICS and SABA with a PMDI. You can see the footprints there, and you can compare it to using a DPI plus a SABA PMDI, or a PMDI using just ICS formoterol. But the big difference is if you use it DPI, the MART therapy alternatives with a DPI, then there's a very large difference when it comes to carbon footprints. So the strategies that can be used to reduce the carbon footprints of asthma and COPD therapy at the moment, I think, to summarize, is replacing PMDIs with DPIs in ICS and ICS LABA maintenance treatment, to replace PMDIs with DPIs in SABA reliever treatment, to reduce the need for SABA by improving asthma control, and to reduce the need for SABA in asthma management by switching from SABA to ICS formoterol as a reliever therapy in asthma. But as you know, some people will still need PMDIs, and there is a development now to try to introduce new propellants that has less carbon footprints. And these are the two hot candidates at the moment, HFC 152A and HFO 1234. And you can see that the carbon footprints of these inhalers are much lower than the ones used at the moment. So that's very good news. But the problem is, of course, that there's not here yet. And we have a sense of urgency because at the moment, it's not so much related to the UK, but for the rest of Europe, there are new European parliamentary regulations coming, banning the use of HFCs with these potent global warming potential effect. And this was what it looked like last year. There was the possibility that we would get an export ban already 2028 and a completion of transition 2030. Now, I think this has been changed now to give more possibility to really develop these propellants with less global warming potential, but still the use and the production of the HFCs used now in our inhalers will probably stop in a time period that is not so distant from now. So we really need this development to succeed, but at the same time, we need patients being transferred from PMDI-based treatment to DPI-based treatment. So what can we do? Well, I will try to give you some examples from my own country. In my country, just by luck, most of the treatment is based on DPIs. And during the last years, there has been quite a lot of written about this. in guidelines from different organizations. So this is from the Swedish MPA. This is from my own Society of Respiratory Medicine. This is from the Doctor Society, just describing the problem of the use of HFCs in PMDIs and the negative climate impact that they have. And because of this, inhalation medication for lung disease should primarily be based on DPIs when that is possible. And I know you have similar writings from the BTS. And also, we're looking at our neighbors, Finland and Denmark, and there was a mistake here with the Norwegian there, but it's the same kind of writing. That if it's possible, if you have a patient with asthma COPD, try using a DPI and not a PMDI. And what I think is quite exciting is that when we look at the new GINA version and saying what kind of inhaler should you be using, well, you should of course look at what inhalers are available, which inhalers can the patient use correctly after training. And of course, it's important to follow up that the patient is satisfied with the kind of inhaler he or she is using. But one should also look at which of these inhalers has the lowest environmental impact. And in that case, it will be a DPI or a soft mist inhaler. It will never be a PMDI, at least not with the propellants we're using at the moment. Now, this is fairly simple, but I think more difficult thing is what to do with the patients. Because it's so important that patients are using the treatment, the best kind of treatment, the treatment that benefits them. And we don't want them to feel shame because they're using a treatment that has negative effects on the environment. And I think that's something that we really would be interested to discuss. What is your strategy for this? What we have been doing is that we have tried to work with the patients' organizations, and this is Asthma Allergi-rapporten, which is one thing coming out annually, trying from a patient's perspective to summarize what's happening in asthma and allergies. And I don't expect you to read Swedish, but here you can see a summary of the English translation, and that some MDI propellants inhaler combinations can equate nearly half a ton of carbon dioxide equivalents in 1 year per patient, and this is roughly equivalent to driving 2,500 kilometers with a large petrol-powered car. And the comparison with the DPI treatment, as I said before, 17 kilos per year. But we also acknowledge that at the moment, the environment impact is low among patients. And the responsibility for the kind of treatment that a patient is using in asthma COPD, I think should still be with the doctor. And it's important that we don't give the patients a bad conscience of what they're using. And anyone who has a chronic illness should receive the treatment and not refrain from using inhaler they need for climate reasons. But at the same time, as we said before, for the vast majority of the patients, there's absolutely no reason to use a PMDI when you have DPIs, because DPIs are at least as effective. Now, if you change treatment from a PMDI to DPI, or I mean any kind of switch of inhalers, patient counseling is really critical. And I know that both the UK and Sweden, we have a network of asthma COPD nurses that can be really helpful in educating the patient on the correct use of different inhalers. So it's, you can't just change the prescription from a PMDI to a DPI. You have to have patients counseling also. So how effective have these measures been in my country and the other Nordic countries? Things I've presented to you. Well, to be honest, it's been rather difficult because there has been an increased use of PMDIs because there have been new products available on the market, and trying to change that is as difficult as trying to control an oil tanker. So if we look at the PMDI use by country across Europe, you can see that except for the UK, we're already reached the ceiling. There has been, or at least in most countries, an increased use of PMDIs since 2011. And here I outlined the Nordic countries, and Sweden is still the countries with the lowest use of PMDIs. But even in my countries, there has been an increase. And this just shows that the work we have to do to get a more environmental friendly inhalation therapy for asthma COPD is something that we really have to work quite hard with. So my country was fortunate at 2011 because of other reasons than environmental consciousness. DPIs were really dominant. They are still dominant, but not as dominant as they used to be. And to summarize this, before I hope we can get a good discussion, DPIs has been the dominating inhaler type in Sweden. But in Sweden, as in many other countries, the use of PMDIs have increased. And working with patients organizations, and the respiratory societies is important in order to increase the use of green inhalers. Thank you for listening, and I really look forward to hearing your comments and have a good discussion.
Thank you so much, Krista. That was really interesting, and I can certainly see that that plenty of people have been commenting. So I think we've got one or two questions on the chat, and then I might hand over to Artie to ask some of the questions from the Jamboard. So from the chat, we've got a question from Deb Leese. Have there been any studies that show that the better asthma outcomes in Sweden are due to the increased use of DPIs or other reasons, as we have one of the worst asthma mortality rates here in the UK, and Deb speculates that this might be because lots of people are using MDIs and using them incorrectly.
Yeah. Well, no, I don't think there has been a really good studies looking at that, but it is true that many patients are using inhalers incorrectly. To be honest, I think that is also very relevant for DPIs. It's so easy to make mistakes when it comes to inhalation therapy, and it's something that we always have to work with. But I guess there is a benefit with DPIs when it comes to coordination. I mean, of course, if you use a PMDI with a spacer, this problem disappears, but most patients seem to prefer to use a PMDI without a spacer, and then you do have this problem with coordination.
Sorry, I'm still muted. And we've got a question from Veena Agrawal asking about why you think the MDI use in Sweden has gone up.
Well, it's kind of interesting. As I said before, there is one company in Sweden which is has a very strong position when it comes to respiratory medicine, and that's AstraZeneca. And at the moment, they're moving from promoting DPIs to PMDIs because that's where they have the new product. So I think that's what's happening.
How frustrating that
yes, very frustrating.
Going in the wrong direction.
Yeah.
And one more question for the chat before I hand over to Artie with Jamboard. Emily asks, what is your view on using a PMDI SABA for acute exacerbations when a patient usually uses a DPI for their maintenance?
Okay, so I mean, it depends on how. I mean, there are data showing that a SABA DPI is as good as SABA PMDI, even in emergency treatment. But I must a myth that if a patient comes to the emergency ward in Sweden, we use either nebulized SABA or we use the PMDIs with spacer, because it's, I think, easier to give higher doses. So, I mean, we still need PMDIs, I think.
Thank you. Artie, are you happy to ask some of the questions from the Jamboard out loud?
Yes, thanks. Thanks, Jenny. So we've got quite a lot of questions on the Jamboard.
Oh, that's brilliant. Thank you.
So I guess sort of following on from some of the questions that have already been asked, we always talk about who some people need an MDI. So who would you say still needs an MDI inhaler?
Well, small children.
Mm-hmm.
I mean, you can't use a DPI before the age of maybe 5 or 6. That's a very important group. And then elderly people that need help with their with taking the treatment. That's an important group also. One group that people think needs PMDIs, and even my colleagues, I must admit, is patient with severe CPD. But this is mostly incorrect, because usually, even though your expiratory flow is dramatically reduced, your inspiratory flow is often quite okay. So they usually can use a DPI. And there's a great misunderstanding there, at least from many of my colleagues.
Yeah, and I think you've sort of answered this question, but it is a question that people get asked a lot. So do you worry about asthma attacks and being able to use a DPI during an exacerbation, during an asthma attack?
Well, I mean, that's the difference between our different countries, because as almost all the patients in my country, they have an AccuHaler or a turbohaler, which they use for treating their asthma attacks. I'm not worried. But when they come to the hospital, we usually give the treatment then with a PMDI with a spacer. But it seems to work.
Yeah. So
90% of Swedes can't be wrong.
And I know you answered the question before about outcomes related to the percentage of MDI DPIs used, and we can't necessarily make that correlation, but you definitely don't have worse outcomes. I think we've got some of the worst outcomes in Europe, in the UK. So there's a question here about the terminology. Let me just see if I can find the question. It was a question about, do you call them dry powder inhalers when you're prescribing them? Because some people are finding that puts people off.
We call them powder inhalers,
okay,
if you translate it to Swedish.
Okay.
Pulverinhalatorer.
Lovely. And when you know, in this country for many, many years, we were prescribing the MDI inhalers as default. So we weren't offering people a choice. We weren't saying, there are all of these inhaler devices, which one would you like? We were just prescribing a PMDI inhaler. Was the DPI inhaler default in Sweden? Were you sort of prescribing that first line and not offering people you know, an MDI inhaler, or was it sort of an assessment as to which inhaler was most suitable for them?
No, I think it became the default choice, to be honest. We got so used to the dry powder inhalers that we didn't think about using anything else. But now that has changed a bit. At least I think the change has been for CPD, not so much for asthma. I think it's partly because of a misunderstanding that if you have CPD, your breathing is so bad, you can't really get the inhalation flow needed for a DPI, but that's actually not true.
Yeah, lovely. So I think a lot of these questions are very sort of similar. There's a question on cost. Are DPI SABAs more expensive than PMDI SABAs in Sweden?
No, they're not.
Okay.
It's the same price. And of course, for the patient, it's subsidized quite a lot. So it won't make any difference for the patient, but not for the health authorities either.
And that's sort of quite a broad question here, which is, I think you kind of covered when you talked about your 4 strategies in your presentation, but any advice you can give us on how we can make the Swedish norm of dry powdered inhalers the norm in the UK?
No, I think that's something to discuss. I mean, one thing is trying to influence, of course, the doctors and the guidelines, but the other thing that, I mean, we have to discuss is whether we should try to influence the patients also. I mean, in many, if you buy food today, you can see the carbon footprints of different food products. Perhaps you should see it on medications also. But I mean, the risk is that you green shame the patient, so you don't want to do that. So it's a bit tricky, and I would like to hear your thoughts about that.
Mm-hmm. So I'm going to interject with one of my thoughts here, which is that in my experience, I found when I'm assessing inhaler technique, I tend to recommend dry powdered inhalers because the patient finds it more convenient. It fits with the deep and quick breath that they're incorrectly taking with their PMDI. They're not using their spacer anyway. They don't know when their inhaler's empty. So a DPI sort of supports their control better. And so I would say for more than 90% of my patients, it's a clinically more appropriate choice rather than it being you can use both of them just as effectively, and this one's more environmentally friendly. Would you like to move to that one? So
I see, yeah.
So I feel we're more likely to shift more people just by doing a good assessment of how they're using their inhaler in the first place, and then switching them on the basis of the fact that they're not using their PMDI very well at all.
Yeah.
For those of you who don't know, there is a visual resource to support you to have that conversation on the Greener Practice Toolkit, which is currently in the process of being also branded by other organisations like Primary Care Respiratory Society. Let me have a look at some of these other questions.
Well, I saw a comment that SABA PMDIs, no, SABA DPIs are 3 times more expensive than SABA PMDIs in the UK, and of course that's a problem. But at the same time, I mean, one of the things we like to do is really to reduce the need for SABA, at least in asthma. And I think the new guidelines are, if they are implemented, they should be quite effective in doing that.
Laura, would you like to come in here?
It's LJ.
Sorry,
hello.
LJ.
No, sorry, you're just reading the names. It's fine. Yeah, I was just going to say, I think we've been a bit slow to adopt the SABA-free pathways, and I think they're a real opportunity for us to switch people to DPIs when appropriate. But if we're changing their regime anyway, it's sort of a natural point at which to also reassess what type of inhaler they're on. And I think implementing more AIR, so anti-inflammatory reliever therapy as PRN for mild asthma, and MART for those with more severe asthma, I think is perhaps an easier sell to clinicians. I think there are lots of clinicians who don't feel comfortable switching people if they feel it's for environmental reasons only, even if the patient can use any inhaler absolutely fine. I think you're right, Artie, that lots of people actually, when we do an inhaler assessment, they should be on dry powder inhalers because they're natural. Most of our natural instincts is to take a quick deep breath. So I think selling it like that is right. I think this is also about culture, isn't it? So as you very brilliantly described, the culture in Sweden has been to have dry powders, and everyone has them, and you get used to prescribing them and using them, and they're the norm and they're what people see, and that has not been our culture. So trying to change culture is exactly as you described, trying to turn that tanker around. So I feel like the Air MART adoption, which is making its way into lots of guidelines at a very local level now, is a new opportunity to kind of really invigorate this again. Do you use a lot of Air and MART in Sweden, and do you use it with younger people too?
Yeah, I think the Air thing is really taking off now, and that's at least what I hear from my colleagues in primary care and so on. So I think that's really is going to be a success. I must say that the MART thing has been really slow when it comes to adoption, but I think Air And because of that, MART will take, I think, a movement forward for that. And of course, the main thing is to increase asthma control. But I mean, it's good that we get this environmental benefit also.
Lovely. So I feel like you've probably answered most of the questions that we have on the Jamboard. There was one question here about, well, more of a comment really about uptake of dry padded inhalers being more difficult in deprived areas. And I don't know if you had any thoughts about that.
In deprived area, yeah. Can you take the question again?
So, I mean, it wasn't really a question.
I was looking at the chat, so I was.
Yeah, no, that's fine. It was. I think it was somebody's reflection on how they found. Oh, Richard, you want to just come in?
Yeah. You're muted.
Yes. Sorry, that was me that brought up. I'm a locum GP, so I go around a lot of different GP surgeries in a lot of different areas. I also have a daughter who lives in Stockholm.
Wow.
And I've visited Sweden many times and experienced the healthcare system there firsthand, which I was very impressed by. Anyway, so one thing I've noticed is that the uptake of inhalers is quite geared to or connected to what everybody else has got to do. So if there's a lot of other health concerns, deprivation status, I mean, the healthcare in inner cities, such as Gloucester or inner city Bristol or Swindon. I mean, I'd love Dr. Janson to come and visit Swindon sometime. Absolutely.
I look forward to that.
I mean, compared to Gothenburg or Stockholm or something, it's quite different. It's a bigger population in the UK by far. There's lots and lots of difficult issues, and particularly, of course, the NHS is really going through a massive struggle at the moment in terms of funding, in terms of which is spilling out into survival ratings for cancers, for cancer treatment, and all this kind of thing. So I'm just thinking that the whole inhaler thing has been sucked into that general slight dysfunctionality which is going on in the NHS at the moment, and which is particularly emphasised in the cities. That's a bit of a blah blah, but
no, but I agree. But I think that's what's so good about the air thing. I mean, one inhaler whenever you need it, and you still will get an anti-inflammatory effect. I think that's brilliant, because we have to make it simple to have the patients with us. So I think that is great hope of adapting that.
I mean, I was after surgery recently in the Forest of Dean, and almost everybody refused. I was there for a few weeks, and I decided to change everybody onto DPS, and almost everybody refused. The practice nurse was extremely sceptical, I must say, and I didn't. I was slightly skeptical about the whole environmental thing, but once I'd explained it all, but the clientele almost unanimously, because nobody had used it.
Okay.
Nobody was using them. So it's this cultural thing. It's once you get the ball rolling, once you start turning the wheel on that oil tanker, you'll start seeing the difference many sort of months down the line. But I think in a sort of acute intervention, it's quite difficult.
But I mean, we have to have the nurses with us. That is so important. I mean, they have a very strong position in the UK and in Sweden, and they're very important partners to work with.
Yeah, one of the questions that I wanted to ask you as well, because I agree with LJ that we've got two changes coming along in in asthma care. We've got the move towards dry powdered inhalers, but we've also got the move to combination inhalers and air and mart regimes. And it makes a lot of sense to do those two changes at once. So whilst we're telling the patients, do you know, instead of having two separate inhalers, lots of people find it much more useful, much more convenient to be on one inhaler that does both things, to also then say, and I wonder which device is the best one for you, and make those two changes at once. Because as somebody else has said, you know, there's only so many changes healthcare professionals are likely and patients are likely to manage. And the change that we've done in the UK has been the change that hasn't required assessing the patient's control, which is just the change from Ventolin to Salamol. So that change has happened, but the other changes haven't. I wanted to ask, in Sweden, do you have a problem, seeing as you've been using dry powdered inhalers and the separate preventer and reliever inhalers, have you had a problem with compliance with preventer therapy? So
no, not
that need to move to combination.
I can only really talk about my own patients, but I don't think this is a problem, because Symbicort and the other Bufomix have been around for such a long time that it's seen like a normal therapy. I think the problem is convincing the patients that they don't need their Ventolin anymore. I mean, that's the problem. I'm not always successful in that, but I try. And some are really happy.
Wonderful. So any other questions from
there was one I spotted. Oh, sorry.
Yeah.
Sorry.
Choose the different DPI devices. Well, we have basically 3 to choose between in my country. I think 4. And I think one should choose the one that you as a doctor feel most comfortable with. The dominating ones in Sweden at the moment are AstraZeneca's Symbicort and Orion Pharma's Bufomix. It might be called something different in the UK. I mean, as long as the patient knows how to handle it, it's okay which one you choose. It doesn't really matter.
And just to add, I'm sure people already do this, but trying to have the same device if they have more than one inhaler. So if we're having just one inhaler, then there's really an open choice, isn't there? It's whichever one the patient prefers, although there might be some pressure because of price, I think. But if they do have more than one, or they've been on a separate ones before and got on well, for example, with a turbohaler, you would stick with the same one, I'm sure.
Yeah.
I think we haven't used turbohalers enough here. They're pretty well liked by patients, but they've been further down our list.
They're quite good. I mean, one thing which is good with them, if you look at the air therapy, is that they last so long. I mean, if you have even if open turbohaler, if you treat it the right way, it lasts for 3 years, and that's fantastic. If you have a treatment that you also use as a reliever therapy.
So we've got something in the chat here from Froome, who've had a lot of success, it seems, with moving people onto dry powdered inhalers. And I wondered if, Richard, you want to just come on and talk about what you did. So.
Hi, yeah, sorry, my camera's not working on my laptop at the moment. But so yeah, I'm not a clinician, but yeah, our meds management team and our asthma nurses, along with the with GPs as well, have sort of over the years now come up sort of through lots of trial and error, like learning as you go, we've got a dedicated member of the meds management team who are able to do a pre-assessment almost of patients before their asthma review, and to then send out all of the reasons for changing, and sort of giving the option to make that change, and then that can be followed up then with at the asthma review to have that more detailed conversation. So those asthma nurses aren't having to start from scratch in the conversation, essentially. We're doing some work at the moment to write up our learning as well. So that'll be available on our website in the coming weeks when I get round to writing it all up. So yes, yeah, there's it's a long journey. I think it is about the cultural change, and it's about having the buy-in from all at every patient contact point as well. You know, having that consistent messaging. So yeah, we've also found that there's work to do with local pharmacies as well, making sure that the stock is there available, having conversations around when you're doing this work, that they're there and ready. Also working with secondary care. So when people are prescribed inhalers when they're coming out of hospital, making sure that hospital stocks are there for DPIs, and that DPIs are the first line as well. We've also found that the formularies don't always offer second line DPI inhalers too. So that's required work locally for us as well, to work with our ICB to do work on that too. So yeah, there's lots that factor into it really when it comes to making sure DPIs are front and center of your prescribing, I think. So yeah, happy for anybody to get in touch with us at Froome if you're interested in the work we've done. We've got some presentations that we can share and things like that as well.
Brilliant, thank you, Richard. We may well be in touch with you and in the future. But I'd be lovely to hear more about your successes. There was just one other question a little bit further up in the chat, sort of on a bit of a tangent from the use of the inhalers, just about the disposal of the inhalers. Here in the UK, the sort of pilot national recycling programme that was run by GSK came to an end a couple of years ago, and there is no national recycling programme at the moment. Do you have anything in Sweden for recycling inhalers, or if not, what's the disposal process?
No, we don't have any. Well, I'm not sure about the DPIs and so on, what's done with them. We are supposed to leave them to the pharmacies, but at least there is no recycling that takes care of the propellants. I know that, because that was the big thing about the pilot project in the UK. But even though it was, successful, it was only a quite small amount of the inhalers that were really taken care of. So it's difficult to recycle.
So yeah, I think that just tells us that's definitely not the solution, even if it were an option.
No,
so we need to be looking at that upstream, really, don't we? Brilliant. So we've got a few more minutes left. Does anyone have any other questions that they want to add on the chat or to speak out loud, or equally any comments on work they've done, ideas they've thought of, or challenges they've faced?
Richard, there's something?
Yes, hi. Yeah, I just put a comment there as well. I was chatting just with some non-medical people out in Stroud locally. Chris, it's the little place in Gloucestershire, which is in the west of England, and it was quite a sort of political crowd that I want to sort of hang out with. And I just brought up this whole subject of the carbon footprint of inhalers, and nobody had heard about it. And this was quite, a well-connected people, a bunch of people who prided themselves on knowing about political stuff. But I've never seen a public information campaign or to discuss this on the media, on TV, newspapers, or anything like that. And it's, I think if people did know about it and then would go to their GPs or their doctors or their nurses and to discuss this, I think it would make a big difference. And I think that's maybe one of the missing links. We're very much concentrating on what we can do in a medical context, but of course, I always think it's much more useful if people know about it first and then pressurize their doctors or whoever it is.
I agree.
Does that happen in Sweden? I'm not sure.
No, we have the same problem in Sweden. I've been to several, debates and so on with politicians, and whenever I bring up this, I think, oh my God, is this true? And they're always so surprised. And I've been working with this, like, I don't know, 4 years maybe, and there's still this feeling of surprise. So it's not a message that's that easy to penetrate for some reason. Yeah.
As LJ mentioned, Arti featured in, I don't know if anyone listens to Radio 4 Inside Health, but in terms of things that are kind of publicly accessible, aimed at the layperson, that was a really, really excellent summary that just made it make so much sense, with a fantastic patient interview as well that really kind of brought it home. But of course, that's only going to reach the people that are listening to Radio 4's Inside Health. So yeah, a great example of one way of spreading the word, and I guess we need to think about other ways as well.
An interesting thing in the UK is that people have very different opinions about this in the UK. There's been some really strong opinion leaders in the respiratory field that's totally anti this kind of thinking. You might be aware of that.
That's interesting that you bring that up. I think that is a huge challenge. So we've talked about the consistency of messaging being so important and patients getting the same messaging. And absolutely, there are some people with very strong views that actually switching patients is the wrong thing to do. And we have to counter that a lot. And I guess that sucks some of our energy, countering those narratives, which then it takes time away from other things. I think there is an opportunity. You've mentioned the inhaler recycling, so that there is still scope for an inhaler recycling program in the UK. There are some pilots happening too at the moment, supported by Greener NHS. I think if that led up to a national campaign, the conversation around inhalers in general would then be increased, because I don't think there's much appetite for any public bodies at the NHS or Greener NHS or any of those to fund a kind of national information campaign, unfortunately. So it would need to be tagged to something else. So I wonder whether maybe that might be a win, but it's really difficult. Yeah. Any advice for how we counter our colleagues' advice? I know you have done in the past. You've been excellent.
No, but I think it should be part of, you do have targets to make the NHS carbon neutral and so on. I mean, this is one jigsaw puzzle, part of the jigsaw puzzle to accomplish that.
LJ, I don't know if this helps, but my sort of way of countering that is it's quite challenging actually. I sort of say we're talking as if asthma care is good in the UK, and it's not. And if you look at the asthma and lung survey results, only 20% of patients with asthma are fully controlled and 40% are uncontrolled. So we need to change something, and we should be looking at asthma review. We're not talking about our asthma control is brilliant. If we change something, we're going to destabilize it. No, our asthma control is poor. We need to change something to improve it. So starting from control sometimes brings people together rather than starting from the environmental impact. But that's just my particular reflection.
Thank you,
Danny,
Arti.
can I hand over to you?
Yes, I was just going to say, so we've got 1 or 2 minutes left, so I think at this point it's best that we wrap up. So firstly, I just want to say a huge thank you to Prof. Krista Janson for speaking to us today and giving us some really useful insights, both from an evidence perspective and a personal experience perspective. And thank you to everyone who's shared their questions and their experiences, and also some really great ideas and examples of where things have worked in the UK. It might be a big tanker to turn around, but if we all do a little bit, then hopefully we can. And if anyone wants to add any further ideas to the Jamboard about future sharing hours, we aim to have them every other month. So our next one will be in March, and information will be posted on the Centre for Sustainable Healthcare Networks. So if you're not already a member, please consider joining. There's a primary care network, respiratory network, nursing network, and many, many more. So keep an eye out there for the next link for the next session. And thank you all so much for taking part.
Thank you very much. Bye-bye.
Thank you so much for your time.